the panelists. So on the far end is Dr. Richard Deming. Many of you know him. He's the medical director of Mercy One Cancer Center in Des Moines, Iowa, and is the founder of Above and Beyond Cancer, which is a public nonprofit organization dedicated to elevating the lives of those touched by cancer to create a healthier world. Dr. Deming obtained his BS in chemistry and microbiology from South Dakota State University. He obtained his MD from Creighton University School of Medicine, and he completed a residency in radiation oncology at the University of California, San Francisco. Prior to his work in oncology, Dr. Deming was an undersea medical officer for the U.S. Navy. He recently created the integrative oncology practice within Mercy One Cancer Center, and is interested in a holistic approach to human health and a holistic approach to Earth's health. In the middle, we have Dr. Sarah Nash. Dr. Nash is an assistant professor of epidemiology at the University of Iowa College of Public Health, a member and co-lead of community outreach and engagement at the Holden Comprehensive Cancer Center, and director of research, analytics, and dissemination at the Iowa Cancer Registry. Dr. Nash's research bridges population-based data science and community-based work to address cancer health equity, specifically focused on American Indian and Alaska Native cancer burden and weight-based disparities in cancer care and outcomes. Prior to her current appointment at the University of Iowa, Dr. Nash was director of cancer surveillance and PI of SER, Alaska Native Tumor Registry at the Alaska Native Tribal Health Consortium. And finally, we have Dr. David Courard-Hauri. He is the William Ashton Professor in the Department of Civil and Environmental Engineering and a professor in the Department of Chemistry at the University of Iowa. His research broadly focuses on water quality and water treatment, with particular interest in the intersection of public health and policy. At UI, he directs the state-funded Center for the Health Effects of Environmental Contamination, CHEEC, I guess is how you wrote it, right? Which conducts research to identify, measure, and prevent adverse health outcomes from exposure to environmental contaminants. So, So what we're going to do today is, I have several questions for the panelists, a few questions for individual panelists, and a few questions for the group as a whole. And then we're going to open it up for your questions for the different panelists. So let's start, Dr. Deming, with you. Iowa's made headlines for having the second highest cancer incidence rate in the U.S., with lung cancer ranking as the deadliest form of cancer in our state. You're passionate about both human health and the health of our Earth and planet. When it comes to cancer, how are these connected?
Well, we are all interconnected, and I think that that's something that we realize, that there's no part of our society, our environment, our life that isn't connected. And I think that it's always looking at risks and benefits of everything. So when you look at the cancer incidence in Iowa, it is alarming that we are number 2 in the country, second only to Kentucky. We think we know why Kentucky ranks so high with their very high smoking rates and coal mines and other factors. We are perplexed by why Iowa is so high and why we're the state with the incidence that is going up the fastest of any country, any state in the union. So there's modifiable risk factors that we can study, and we can look and see, okay, where are we compared to smoking, obesity, physical activity, alcohol consumption, HPV vaccination, sun exposure, diet, fruits, vegetables, etc. And, you know, we're not a huge outlier on many of those. There are some things that aren't studied to the point that we have a direct association. But as, now I'm a doctor, I take care of patients, but I'm not a hard scientists doing that work of the p-value of showing that this risk factor is causing this cancer. But if you just look at it as a human being and you look at the map of Iowa and you look at the surrounding states and you just say, what do I think is different about Iowa that could be contributing to this very significant difference in cancer incidence? And two things come to mind that I think deserve more study. And one is the amount of radon that we sit on compared to the surrounding states. And we know the association between radon and lung cancer, but having studied radiation biology as part of my radiation oncology, it wouldn't shock me that we learn over time that some of the other cancers may also be associated with radiation exposure, in particular radon. But second, when you look at our beautiful, fertile farmland and how much of our square footage is covered by crops, and not just crops, but by herbicides, pesticides, insecticides, and fertilizers. I'm not saying those are all bad. They do many, many, many things that gives us great yield. But when you look at the amount of chemicals per square inch of Iowa compared to some of the surrounding states, it's logical to wonder to what extent does that contribute. So back to the interconnectedness. As a cancer doctor, I get the opportunity to try to impact cancer one patient at a time. But as an advocate for public health policy, I feel strongly that using a voice to try to figure out the problem, come up with a solution, can have the impact on reducing the burden of cancer for many, many millions of people.
Wonderful, thank you. And I think we'll get back to some of those points in a little bit. But Dr. Nash, some of your research addresses cancer and health equity. How do you think environmental factors impact the picture and the outcomes for people who are most disparately affected?
Thanks for the question. Like Dr. Dunham said, cancer is really complicated, and cancer disparities are also really complicated. Where we actually see the highest disparities in terms of cancer incidence and mortality is among Iowa's Black population. So we have the second highest incidence and second highest mortality in the nation among Iowa's Black population. And we've been working at the Human Comprehensive Cancer Center with different community groups to try and figure out why this might be. Again, like Dr. Deming says, I'm not an environmental health person, but it's hard for me to imagine that those disparities are really being driven by environmental forces. To me, seems more likely that there are structural and social inequities that are driving different health behaviors that are related to those cancer disparities. But it's definitely something we need to figure out. I think we need to kind of work with our communities, try and understand what's going on in the communities. And then in terms of kind of rural-urban, we actually find like Dr. Deming said, our cancer rate is one of the highest growing in the union. And that's really, it's increasing in both rural and urban Iowa, but it's mostly that the slope is higher in our urban areas. So I think we really need to figure out kind of what's going on there and trying to figure out where we see these disparate outcomes and why they might be happening.
Great, so lots of research potential.
Lots of research potential.
Good to know.
Any budding researchers in the audience. Lots of unanswered questions.
All right, Dr. Swartney, the Center for Environmental Health Effects and for Health Effects and Environmental Cheek. So thank you. There you go. So Dr. Swartney, Cheek, publishes a lot of research about contaminants in Iowa's water sources. Could you highlight a few findings and their potential to the potential connection to certain cancers?
Sure. So I took over Cheek in 2017. The prior director was Pete Wire, and Pete Wire was an epidemiologist that worked extensively with the National Cancer Institute and researchers there. And I'd say the work that Cheek is probably most well known for is the work that they have done, Pete and those collaborators, on potential links between nitrate in drinking water and different forms of chronic health impacts. So many in this audience probably know that we regulate nitrate in drinking water at 10 milligrams per liter as nitrogen, primarily for blue baby syndrome. It's an acute health impact, meaning if infants drink high nitrate-containing drinking water, adverse health effects start immediately. And what that is nitrate gets transformed in the body and it interferes with the way in which oxygen is transported. Babies will turn blue from oxygen deprivation. It can be fatal in extreme cases. So that's what really was the impetus for the regulation at 10 milligrams per liter is N. That was back in about the late 80s. Since then, there's been a growing number of studies, including the ones led by Dr. Weyer, that have found potential associations between nitrate in drinking water and chronic health impacts like bladder cancer, colorectal cancer, thyroid disorders, as well as birth defects. And so realizing that it's more potentially than just cancer. And in those associations, many of them were found at levels of nitrate in drinking water below 10 milligrams per liter is N, so below the Safe Drinking Water Act standard. These studies, there have been studies in other parts of the world that have found similar associations, particularly around colorectal cancer. And I will say that those studies have been cited. The EPA is currently undertaking as part of its 6-year review of standards in drinking water. They are looking at those studies to reevaluate the role that nitrate in drinking water, distinct from nitrate through diet, might have in terms of chronic health risks like cancer. So that's historically what we've done, and we still focus on nitrate burden on Iowa consumers today. Many of our larger utilities in urban areas use surface waters that are most vulnerable to high nitrate. And I would also say that we have about 400,000 private well users, many of which are using shallow wells that are routinely prone to high levels of nitrate, sometimes pushing 40, 50, up to 100 milligrams per liter. More recently, we are doing what we can to close monitoring gaps in Iowa. Whether we like to admit it or not, there's a lot we don't know, and we aren't being proactive in measuring the extent of exposures that we might be having in all of our populations. And I think probably one of the things we can focus on there is perfluorinated chemicals. You've probably all heard of forever chemicals, or PFAS. These are chemicals that were used widely in industrial and consumer processes and products. We all have a little bit of PFAS in us, unfortunately, from their widespread use. There's a lot of suspicion that these are cancer-causing agents, particularly some of the legacy ones like PFOS and PFOA. I would say we're well behind on really establishing the problems and burden of PFAS in Iowa. We've done work with the USGS to find them in our rural streams, in discharges from airports and other industrial sites. We find them in private wells. So while we focus on nitrate, while we focus on other vulnerabilities, we shouldn't forget that we're still figuring it all out in terms of what else might be there, what might be a problem in some communities and not others.
Well, thank you. One of my personal reasons for wanting to do this was I need to know if I need an RO filter under my sink. So you can, hopefully by the end of this, I'll know the answer to that.
I will answer that.
Great.
Can you answer it first?
So I basically say that if anybody has the means to get an RO device, it's the safest way to protect your residents from just about most of the chemicals that you would worry about, whether it's lead, whether it's PFAS, whether it's nitrate. RO is about as good as you can do. There are challenges. It's about $1,000 to install one and probably a couple hundred to several $100s a year to maintain it with new filters. So as we think about disparities in access, that's a big one. Who needs it most likely can't afford it. And so I'm a big champion for figuring out how we get the state to help people get access to those. I always bring up that Nebraska did it. If Nebraska can do it, we can do it. It always gets laughed. Thank you. But I mean, seriously, like there are things we can do today to lower people's risks and have significant health outcomes because, again, you catch more than just the things you might be worrying about. So if you can afford it, do it. But let's also appreciate that many can't and probably need it.
Thank you. All right, so let's start more of a general conversation. So the World Health Organization attributes about 25% of COPD deaths to outdoor air pollution. We know that coal plants and other sources of particulate matter pollution are associated with negative health outcomes. Those health outcomes include asthma, lung cancer, premature death, those sorts of things. How can that knowledge help inform public policy?
I think, again, everything's interconnected, and it's easy to just maybe condemn every combustible thing that's done. I'm interested, though, in looking at the whole overall footprint, so I'm not going to be a naysayer, but obviously, as we go away from burning things, that will make the environment better. But there is a footprint, a carbon footprint for everything we do, including, making batteries for electric cars. But I think looking at what we can do to clean the air will help everyone, and it's not just a cancer issue. Get back to the same story, risks and benefits. What are we willing to spend, and what are the benefits we're going to reap? And that's always going to be the tug, and that's a real issue. Can I ask a question? David, one of the things that, and this is philosophically looking at, what causes more cancer in Iowa. I'm interested in why is Iowa different? So clearly, there's more chemicals and ag chemicals, and PFAS is one of those. Are you aware if anybody's done a study trying to see which states have more PFAS exposure than other states? It would seem to me, just reasonably speaking, that we probably don't have less PFAS than Minnesota, but I don't know that for a fact. And I'm just curious, there are so many chemicals that have benefited our human life in the 21st century, but it comes at some cost. Are you aware of any attempt to correlate across the United States PFAS exposures?
You're putting me on the spot. I would say that I think early on perceptions were Iowa wasn't going to be in at the forefront of states like Minnesota, Wisconsin, Michigan. So high-profile instances of contamination were, say, associated with industrial discharges near the Wolverine boot manufacturing facility because they were using PFAS-containing chemical materials to essentially Scotch guard or waterproof their boots. And so the communities there were greatly affected. Because of 3M and DuPont and Minnesota and Minneapolis have had a decent amount of challenges due to PFAS. We have some of those industrial uses. I'd be hesitant to say that they're probably not as severe as some of those high-profile ones, but that doesn't mean it's not severe to somebody that could be near those discharge points, right? And I would simply say we don't know. We have not characterized. We were some of the first to test private wells south of the Eastern Iowa Airport and found in the first well we tested PFAS. In the next well we tested, we found the highest levels of PFAS in drinking water in Iowa so far to date, because we bothered to look. So it's hard to say because we're still characterizing. I would say in many instances we have the same vulnerabilities. 7 airports that were required to use PFAS-containing foam. We have plants like 3M, in parts of Iowa. I think Ames, maybe it's DuPont or 3M, I can't recall. We have communities along the Mississippi River whose water is impacted by the 3M plant in Cordova, Illinois that was discharging. So most of our PFAS-burdened drinking water is along the eastern edge of the state in communities that are using the Mississippi River or alluvial water from the Mississippi as their drinking water supply. So are we as bad as any places? I don't know how to characterize it really. We have plenty of communities that are going to be affected, and that's probably sufficient to say we should do something about it.
So something of a follow-up, but Dr. Deming mentioned the costs and benefits of these things, and you had mentioned before kind of EPA reviewing the nitrate regulations, and we all know how difficult it is to remove nitrate from drinking water. I'm just wondering, is there is it possible that EPA could lower that, and was that feasible?
I'm sorry to keep going. When you get tired of me, let me know. So the way it works is every 6 years they do a review, and I have this in my presentations that I give on nitrate. It was actually 2010 when EPA, as part of their second 6-year review, this is the second time they'd done the 6-year review as part of amendments to CIDWA in 1996. In the second 6-year review in 2010, they said there's more evidence about nitrate causing chronic health effects that we need to consider. So what EPA does in that case is they kick it to their risk information, the IRIS, the Integrated Risk Information System. It's the group that does the health assessments. So IRIS they convened a panel and they got working on it, and so the next 6-year review came in 2016. They were still working on it and said, well, we can't make a determination because we're still waiting for that health update. Well, there was an election in 2016, and shortly after the election in the Trump administration, they paused that review, and it did not get finished. It was only until 2023 that the Biden administration restarted it. So 13 years lapsed between when we realized we needed more risk assessment and health assessment to when we're actually finally restarting it and getting it. They've only recently, as of October of last year, outlined what the scope of that would be. That scope cites the studies from Cheek about needing to consider populations like postmenopausal women, which there were clusters that were potentially more vulnerable. So they're looking at it. But when you think about the consequences of the next election, and will that likely keep going forward, I guess two questions I have is why it took the Biden administration so long to restart it, and what happens to it if the previous administration who paused it takes over it again. So that's one of those consequences. I often use that in the context that like a revisionist was not likely going to save us, right? Because it's 16 years waiting here, or however many, 14, and we're not there yet, right?
All right. Do you all think that advancements in environmental monitoring have improved our understanding of cancer risks associated with environmental factors? Are we at a place where we understand those things better now?
This is probably another day of questions.
I got a community question coming up, so right.
So all I'll say in that regard is we do need to close. So there are really advanced monitoring tools, but we got to use them, right? We need to measure. And so we need to apply them to as many communities as possible to understand exposure burden. So yes, there's been advances there. The fact that we can measure PFAS in each of our blood down to very low levels is a huge advance. I think it complicates things too. Like one of the things we don't study well is mixtures, like how we respond. Like we're not getting exposed to one thing, we're getting exposed to a mixture of things. And then on top of that, I'm going to respond differently to that mixture than either of my panelists, right? So what could be bad for me may not be bad for them. So there's part of me that thinks the more we measure, we're just going to like spin ourselves around the axle. And we need to be asking ourselves more and more, when is enough knowledge enough to start changing the way we do things, to minimize exposures in the first place and limit risk, rather than thinking we'll measure to the point where we say, aha, I finally got that data that proves it's this. Because I don't know that that'll ever exist, and even if it did, I imagine it would get politicized and plenty of folks wouldn't believe it.
Can I just add something to that? And
yes.
With full disclosure that I know nothing about environmental management. But I think to add to your point, Dave, that not only is environmental exposure mixture complicated, but cancer is complicated.
Sure, yes.
And it's not just environmental causes that drive cancer. So we like to, anybody in here old enough to remember Trivial Pursuit, the best game ever made? We like to think about cancer as a pie, right? And there are multiple pieces to that pie. And so, unfortunately for some of us, we fill up our Trivial Pursuit pie quicker than others. And there are so many contributors to filling up that pie, and it could be environmental, it could be genetic, it could be health behaviors, it could be many different things. And so it's not just making sure that we get our environmental monitoring right, although that is still important. It's also trying to figure out how those things interact with all of the other things that cause cancer as well, which is even more complicated.
Right. Absolutely.
And all of those complicated connections make it so difficult to come up with a smoking gun. And so some people just say, well, I haven't seen the paper with a p-value of less than 0.05 that proves without a doubt that chemicals cause cancer. But there is data, and I just wanted to point out a paper that was just published in July of this year. It's in Frontiers in Cancer Control and Society, and it's a comprehensive assessment of the use of pesticides, and pesticides includes herbicides, insecticides, and fungicides on increased cancer risk. And the bottom line is that in our part of the country, there may be enough of an association that leads us to conclude that these chemicals have as great a risk as cigarette smoking in the causing of cancer. And I invite you to look at that paper. I'll just show you this, where the big black dot is right where Iowa is. Iowa is right in the epicenter of where the largest contribution of these chemicals all together. In this paper, one of the factors that makes it unique is they didn't try to just take glyphosate or a particular chemical, but tried to look at all of the chemicals together and the impact that they have on increased risk of cancer rates compared to surrounding populations. So it troubles me when I hear some scientists say, well, we just don't have enough evidence to say that these chemicals cause cancer. I think that the more these papers get published, it's going to be harder to hide behind that. We don't have a smoking gun, we don't have a p-value, and to start looking at common sense to help direct us to more research like this. Once we realize that there's a problem, again, there's benefits to using these ag chemicals. What are the benefits? What's the cost? How do we come together to figure out what's the risk-benefit ratio?
Thanks. All right, so, I mean, obviously this is a question that's very large, but what do you think are some effective strategies for reducing environmental cancer risks at either the individual or community levels? What could we be doing better?
Anybody want to start?
Me.
You go first, and I'll go.
I don't think you'll like the answer that I have. So we did some digging at the Iowa Cancer Registry. That's where I come from today. And actually, the biggest contributors to our excess of cancer risk in Iowa are 4 cancers: lung cancer, melanoma, female breast cancer, and prostate cancer. And so I'll let Dave really talk about the environmental potential contributors to those cancers. But one thing I will say is that I think we have things that we can do about those cancers now. We have screenings that we can engage in. We have tobacco prevention strategies we can engage in. We have radon. Dr. Deming's already talked about radon that we can engage in. We have sunscreen. We know we could all be using our sunscreen. So I think there are things that we know that don't necessarily require us to have more evidence that we can be doing now. I'll let Dave talk about the environmental.
So first, that we've had a lot of conversations about that paper. I don't know if some of you all have seen it. A few folks shared it on social media. It has its challenges. I'm not saying we're doing similar work with that pesticide data set. Methodologically, I think a lot of folks have concerns about it. I think at the bare minimum, what it seems to show, and we've seen similar, is that where there's high pesticide use, there's also high cancer incidence rates. But it's very hard in such a simple ecological study, we would call that, to make an association. So I feel like I need to bring that up because I know we've talked a lot about it at the University of Iowa. All that being said, I think there are things we can do differently. I want to re-echo this point of Sarah's too, that there are a lot of factors that contribute, and typically, traditionally, historically, if you look at people's talk on this issue, the environment is way down the list, if there at all. But I would also argue that Iowa's environment's about as unique as anywhere. I'd say that if you've sat in a Farm Bureau meeting, they tell you how one of a kind we are, and we can't do it, nobody does it better, so why wouldn't we think that comes with unintended risks? So, things you can do, things we could do. I think on nitrate, because I do trust the quality of the data in those studies for sure, we need to talk about it differently. Right? So I always show an example from Wisconsin where they have a fact sheet that says nitrate can affect everyone. It's not just a blue baby syndrome thing anymore, right? It may increase risk of colorectal cancer. They talk about it differently. We could do that. We choose not to. I think on pesticides, we could actually get better data. We could make pesticide sales data available so that we knew where they were being used. The data that we get from the USGS is filled out by survey. We don't make the pesticide data publicly available because we say it's proprietary. It's sales information. But there's things we could do to anonymize it and still know where ingredients are being used. Like I said, we could help people get access to treatment. If you're worried about your drinking water supply, we could find out ways to say for private well users, amend the grants to counties program to make some of the funds available to help acquire a reverse osmosis system. We could support robust monitoring at our state hygienics lab. They have one instrument to measure PFAS, and it's a bottleneck. We're never going to get over our bottlenecks if we don't start actually prioritizing research and prioritizing monitoring. And the last thing I'll say is, let's not forget that what makes the environment challenging in Iowa is it's not just the agricultural footprint. Many Iowans, like 60–70%, use groundwater, and many of those deep groundwater aquifers have arsenic, have uranium, have radium. Those are all known carcinogens. We regulate them in drinking water for carcinogens. We don't talk enough about arsenic in Iowa. We think maybe that's like a spot issue in some counties, but we've been working up in Palo Alto, which got a lot of attention for being the second highest cancer incidence in the US, and we measured a well where someone had 4-fold the levels of arsenic in their drinking water. Is it nitrate that's affecting that person? I would say probably not, compared to what we know is an unsafe level of arsenic. So we tend to look past the kind of the obvious risks when it comes to the environment. We should do something about that. So there are things we can do, but I think we also have to appreciate it's that and more, right? This shouldn't be the only thing.
And when you look at how can we modify things, our environment, how can we modify our lifestyle? So in the United States, 42% of all cancers are caused by modifiable risk factors that we have control over. And 45% of all cancer deaths are caused by cancers that we have the ability to control. So I'm here today because I'm very much interested in the environmental effects and doing whatever we can to mitigate there, but don't lose sight of, I mean, the worst thing to think of would be somebody who is overweight, inactive, and smoking, who only wants to go to conferences and picket, ag chemicals. There are things that we do have a lot of knowledge about that we can modify, and let's not lose sight of them. So cigarette smoking is not illegal, but it's definitely not healthy. Obesity, physical inactivity, eating too many calories, not having the right diet, sun exposure, not getting HPV vaccination if you're given the opportunity. I mean, all of those things contribute to cancer too. So it's both and, not either or. And some of those things I do well, some of them. So for example, drinking no alcohol is probably the preferred thing to do if you want to have the lowest possible alcohol risk. Some of us choose to look at it as a risk-benefit analysis. Well, I have a feeling that people laughing also maybe risk-benefit. But the point being is that it's both and. It's not just this crucified ag chemicals, but it's clear that we have the opportunity to learn more and to then talk about public policy, because if our ag policy is all about voluntary means, I think most of the time we find that carrots and sticks are necessary to influence. You want somebody not to smoke, you can lecture them all you want, but raise the price of a pack of cigarettes by $2 with a tax, and you will have a demonstrable decrease in cigarette smoking. I'm getting down.
No, I think that's wonderful. And without taking anything away from that, I am going to go home and tell my wife that Dr. Deming said drinking is fine.
Just say you ran the numbers. Ran the numbers.
So for coffee, I will say some is good, more is better. Seriously, there are studies that show that you drinking up to 8 cups of coffee a day increases longevity, decreases cancer. I can't say the same thing for alcohol.
Totally fair.
And I just wanted to add to what Dr. Devin said, to say that each thing that we think about, each thing that we're preventing, it's one slice of the pie, right? So maybe you have 70 of your 8 slices filled, and if we can just stop that, if we can do radon mitigation, if we can put in a public policy to reduce tanning, we have no policy to reduce tanning among minors, or to eliminate tanning among minors in Iowa. If we put in that policy, if we go get our cancer screening, if we do some of the mitigation strategies that Dave's been talking about, each of these is one less slice of the pie towards our pie being complete in the diagnosis of cancer.
And then I'll also just finally add that it's going to be the risk and burden is going to be unevenly distributed across the state. Some more populations than others, and so Cheek has worked and continues to work with folks from the National Cancer Institute, and they've been involved with what's known as the Ag Health Study. It's about 9,000 farmers and their spouses that they've enrolled between Iowa and North Carolina, and they've tracked just about everything with these people for quite a long time. And so back in 2020, they put out a study that was looking at, there's a couple things you can draw from that study. Like we know that people that actually work as applicators of pesticides will have higher risk, so we need to prioritize those at-risk populations. We also know that living in proximity to some of the application as well as to confinements increases risks of certain chronic diseases. Like in 2020, we published a paper that was looking at distance to confined animal feeding operations, finding higher incidences of some blood cancers the closer you live to confinements. So those are that's about as good as the science gets. You talk about p-values when you've enrolled people, when you've tracked them over time, when you've monitored their diet. You talk to those authors, they'll say there's no reason folks shouldn't think about that increased risk if you're living closer to a confinement. We know we have a lot of people living close to confinements. There was just a report put out today that talks about all of the density of confinement we have. We have at-risk groups, some more than others. So there's an opportunity to just sort of understand that some factors may be important somewhere and not elsewhere. But that's part of that complexity that we've been talking about.
Thanks. And I think I'd be doing a disservice, since we're talking about what you can do, to not ask you, what did they do in Nebraska?
So what they did in Nebraska is they discovered a lot of their private well users were drinking unsafe levels of nitrate. And they said, we have to help it. And so when there was floods of money coming to counties and states through the recovery funds of the Biden administration, through the IRA, they decided to put some of it towards helping folks get access to reverse osmosis systems. There's a lesson in it though, like they made it really burdensome to get access to them, unfortunately, and they didn't spend all the allotment and get a lot of uptake, and so there's lessons. So when I say Nebraska did it, we can do it, we should do it better to make sure people actually get the devices. But at least, they started that discussion by showing, hey, we have money, we should prioritize where we spend it on our most vulnerable.
Did they transfer money from the football team to that project? And that's why?
I think it was an NIL bill or something.
All right, great. So let's end this part of the conversation with what is one thing that you wish every Iowan knew about cancer and environmental risks? So just go around.
I just go back to that. I hope people sort of, when it comes to the environment, understand the vulnerabilities, right? That may not be nitrate everywhere that people should be concerned about. I tend to think, like I said already, that we overlook some obvious ones. I really spend a lot of time thinking about uranium and arsenic, things that we know are problematic when it comes to drinking water, that people might be drinking in their wells all their lives and not pay attention to it if you don't measure. So I think we all just need to be advocating for more monitoring, but also that I think we have more than enough information to start acting. So when you talked about public policy, I think we know plenty to say that we have at-risk populations in Iowa, we should do something about it. So keep studying it, but also understand that we can't study it forever. Eventually we got to say enough's enough and do something.
I really like that message. If I can't choose that message, I guess I'll choose.
You can choose.
I'll add to it to say, just to reiterate the point, that cancer is really complex, and yes, we do need to know more about many things. Yes, we are ready to act on many things, and I think that there are many different pieces of this puzzle that we are ready to move on today. Environmental and non-environmental things that we can really begin to address.
Ditto, I would say that start some demonstration projects around mitigation with carrots and sticks and see what effects you have on the environment and perhaps then what effects you have on health. And then I would also make another plug for learning more about radon. It's a real thing. It's important in Iowa. I think most Iowans don't realize, I think something like 70% of the homes we live in have higher than acceptable rates of radon. It's easy to test, it's cheap to test. It does cost to mitigate, and there again you go back to social determinants of health, and that cancer affects everyone, but cancer doesn't affect everyone equally. So keep in mind, radon. And also, this is sort of environment for some people, a secondhand smoke is something, and third-hand smoke is something. So we still have casinos in Iowa where it's illegal to smoke, and workers have to work in that environment. That's an environmental issue. And it's one thing, first-hand smoking is when you're active smoking, second-hand you're breathing in the smoke, third-hand smoking, and you can have childcare workers smoking on a break and come in and they've got smoke in their clothing or in the furniture, and again, those all contribute and could be construed as somewhat environmental issues as well.
Thanks. All right, so we have about 20 minutes. You have the state's premier experts here. What do you want to know?
That's a lot.
Oh, it's totally true. Yeah, Joe.
Earlier this year, the Environmental Council put out a report on nitrates and human health, where they took some of the studies that Professor Schwartz noted earlier that demonstrate that less than 10 milligrams per liter of nitrate in water is causing certain kinds of cancers. There's an association. They actually, I think, recommended in this report that the standard be lowered to 5 milligrams per liter. When we talk about, is there enough research? I think people think there is enough research. Do the panelists think that we're ready to start advocating for a new federal standard at 5 milligrams, 3 milligrams, instead of kind of continuing to talk about the need for more research? Is there time to put a peg in the wall and say, this is where we need to go, EPA?
I think a lot of that will get resolved if the EPA can finish the health assessment and push that process forward. So that's sort of the official answer. I had a really fascinating conversation with Ted Corrigan over lunch. And we talked about exactly that. And so I think I'm generally in favor of 5. A lot of people have advocated for it. I think it would acknowledge that there's potential chronic effects that aren't captured by the current standard. The reality is 5 would effectively bankrupt many water systems. And so Ted asked me, and I think it's a brilliant point, that there are things like disinfection byproducts, another cancer-causing agent in a municipal supply, by the way, that we don't completely monitor as well as we should, considering some of the emerging ones that are out there. But it's a quarterly average of concentration that instead of a fixed threshold every time of day, if that makes sense. So he was asking, do I think it would be sort of like a yearly average of 5 versus a hard cap at 5? Because if it were a hard cap at 5, lots of places would be in violation without a lot of investment in treatment. I think you could potentially see something like an average that would be a start. You're only going to get there either by investing loads and loads of money in new treatment, and we're not going to do that because we're not doing enough with PFAS in that regard, frankly, or source water protection. We don't need to have the levels of nitrate in our drinking water that we have, and so there's some hope that if there were a change to the MCL, maybe it would be enough to motivate real teeth on source water protection. I don't know why the others feel, but that's...
I defer to the expert.
I would defer to the expert, but I would just say, it does come down to knowing that we can't know everything. How many lives do you think we would save by going from 10 to 5? And what's the financial cost of doing that? But do keep in mind that there might be other beneficial downstream or upstream effects, and that maybe we would have carrots and sticks about nutrient runoff, not just this. These are some good ideas if you guys want to do it, as farmers do it, but have some real carrots and sticks that will mean that maybe we don't have to just invest more in cleaning the water, but that we take care of making sure it's doesn't have as high a level when it comes into the treatment.
Instead of keep slapping them on the wrist every time that they write that off as a cost of doing business. Well, yeah, we got an administrative fee of $2,500, but it would have cost us $5,000 to pump that elsewhere. So yeah, who the hell needs an Ishnabatna? Yeah.
I mean, there's a reason our nitrate levels are high.
it's not just, and there's the other part. I was making the analogy earlier that like I'm tired of getting asked the question, is the nutrient reduction strategy working? Because it's certainly not. After decades, the more we talk about it, the more of a disservice we're doing about actually making a change. The other thing is the nutrient reduction strategy doesn't do anything for anybody on private wells. If you think even just about our surface waters, it basically ignores the high groundwater levels. So eventually, we have to figure out how to keep nitrate out of our water in the first place. And at the very least, we should be asking if we're giving tons of money for the adoption of practices, which we're all paying for, that it should come contingent on seeing real progress in water quality, which we currently don't do. That's absurd. No one should be investing state or federal dollars and not having some level of assessment to make sure it's working, but that's what we do, and that's why we are where we are.
I have avoided saying anything until this point about
What an unnatural act.
Yeah, I'm sorry, I'm doing the whole for it. Okay, so I want to talk about the question of whether the nitrate standard should be a yearly average or should be considered to be something that's a cumulative impact like organics should be. Okay, so I'm a chemical engineer. I started out my career working at Dow's Environmental Research Lab. I worked as an environmentalist all my life helping people solve or lessen their environmental problems. I got asked about 8 years ago to go to Nicaragua and help figure out what's in the water that was causing chronic kidney disease of unknown origin. After Boston University Hospital had spent, I talked to you before, spent probably $5 million in 8 years doing research and found that they can't find any public health and it's got to be in the water. I hooked up with people in Sri Lanka and Australia and Africa who have the same problem. And it's pretty much starts showing up in children as young as 5 when there's 5 parts per million or higher of nitrates in drinking water. Now we saw that in Nicaragua, but there's a peer-reviewed study done by a kidney doctor in Australia that was published in 2020. I sent it to you, in which he shows a mechanism for chronic kidney disease, and she shows that in that part of Australia where there's high nitrates in the drinking water, they need to do something to lower it. In general, I think public health worldwide is ignored it. Boston University has responded by trying to rule out other things because it seems like you've got to do a 20-year public health study before anybody will work on doing anything as policy. And having been an engineer, if I have an 80% confidence that what I'm looking at is the right solution, I will implement it. The Costa Rica does RO in all their water because it's high in nitrates. The people who make Florida Cognac up the road from the little town that I did my research in give all their employees who live in their facility RO water after they saw some of this research, and it has drastically cut that. But what I would say is it's like organic chemical exposure. It's not a yearly average, it's cumulative.
Yeah, so it's good to see you again, and we have been working on that. It's been slow. We are publishing a review of the available literature and looking at nitrate. Some studies have implicated glyphosate, others have just implicated salt salinity and hardness, calcium, magnesium. So it's the same type of questions when it comes to chronic health effects. Exposure for how long to what? I think the most important thing there is to emphasize there are things beyond cancer that water quality issues may be causing, and we shouldn't just get laser focused on the cancer problem even though we have a cancer problem. I am personally concerned about the birth defects studies and the poor birth outcome studies that are out there on nitrate. It is entirely possible there is more going on or other potential outcomes. We're aware of the chronic kidney disease of unknown etiology literature. I will also then say one thing, getting back to that one thing I wish people knew, and I'll say maybe a second thing, is that doing these studies is slow, hard. We got to get access to public health data and medical records that we have to work to get access to and find partners. And nothing happens fast, which is another reason to say if we're waiting for that science, the science we have is pretty good, and we might want to move on some of those things. Lastly, unfortunately, policy does not get made on 80% certainty. I wish it did, it just doesn't. It doesn't even get made on 100% certainty, right? Why don't we have good climate policy, right? There's no doubt that we're causing it. So I hear you, but I think it speaks to how hard and slow this stuff is, and science evolves. The Ag Health Study back in 2004 published a study saying we saw no association between atrazine use and any cancers. They just published a new one in 2024 saying, hey, we followed those cohorts longer, and we're seeing atrazine use correlate with a lot of cancers now in those same applicators. Science evolves, policy does not keep up. It's a challenge. Thank you for your comment.
With respect to the Palo Alto County data, is it still just being studied, or have there been any active steps based on research or presumption as to how that cancer rate can be mitigated?
I know the registry worked with you all and started looking at Palo Alto in response to some of the media attention there. What I would say is when we looked at like the water quality in the area, the nitrate values are unremarkable, right? I know that there's just the first thing we jumped to, but what the folks at Chief jumped to was that's an area where we have these vulnerable aquifers where you might find things like arsenic, uranium, radium, and radon's everywhere. And so that's where we would probably start. So what came about there is the sanitarian or the environmental health specialist reached out to us and said, if I started sending you some water samples, would you measure them? We started with 10 to 20. We're in the process of doing that. But it's the same mixed bag. Some have high arsenic, some don't have much of anything, some have PFAS. They live near the Des Moines River. If you live near a surface water and your surface water is impacting your groundwater, there's a decent chance you've got some levels of PFAS in your drinking water. So we're just beginning to think to do that work and work with the registry to think about their cancer cases, what we know about the environment. But it'll take some time, and we're doing this all with the money we've got. We need more, and that's not really coming, and it takes years to apply for grants, right? So that's a bit of the practical challenges of what we're trying to do is respond quickly, but as quickly as we are able.
Yeah, I think it scares people to talk about 5 parts per million standard because of what it would do to a whole lot of water systems, especially Des Moines, where you have 2 rivers that you could choose among, and they're both too high. There's money also to be got. When you think that when I go down and buy my 10 fertilizer to use in my garden, I pay a 7% tax. When a farmer buys 2 tons of nitrate, he pays 0%. There is no tax. And if you look at something that comes out every 5 years called the Census of Agriculture, it breaks down how farmers spend money and where it's spent. And in Iowa, in the last one, 2022, it was $3 billion spent on fertilizers, not counting manure, which is another amount of additives to make soil better. So there's money if you wanted to put the tax on that and use it then for educating farmers, for helping out Des Moines. So it's not that there isn't money, it's just that we're pretty unwilling to talk about ever putting a tax on a farmer.
Or any polluter. I mean, why is 3M and DuPont still in business after poisoning most everyone's water supply? We just don't do it. If we wanted to, yes, there's money. Same with carbon pollution. So I agree with that, but we've shown no capacity to actually take that as a tax. I wish we could, because it would solve the problem. But so I guess my question back to all of you is what drives that change? Where does that change come from? Because that's what we have to figure out.
General strike.
Question over here.
We're talking about money. In this country, we have a uniquely expensive and I would say broken healthcare system that has a lot of money. So could you maybe talk about how that system impacts some of this? Because it is incentivized by profit, not by prevention. So how does that system impact the work you do, the research, the science? Because they're probably not wanting to know the answers either.
Yeah, you bring up a really good point, and nobody would ever have designed our system. If you said, as a college assignment, just design what a healthcare system should look like in a country. And you're absolutely right that we have the best system for taking care of something that's broken if you have access to the place that will fix that. But we don't have a healthcare system, we have a disease treating system. And there are all sorts of aspects of our current system that contribute to that. I remember being a high school debater in probably 1970, and it was I was still in Vietnam War, and the debate topic for the country for high school students was the military-industrial complex, and how the fact that we made so much money on everything to do with military that just kept us strong and wanting to get in more wars just to help fuel the economy. Well, there's no doubt that we have a medical industrial complex going on right now. There are so many middlemen along the way that are making billions, trillions of dollars, and it's not the people at the bedside providing the health care. And even as a physician, we are rewarded for doing more things. And you get this implicit bias that happens about, what if you could show that doing nothing gives you as good a result as doing something, but doing nothing provides you zero income, and doing something, pays for kids' college. That there are many better models for how should a country look to actually promote health through prevention and early detection and keeping people healthy. I don't know how we're going to get there with so many people making so much money on the current situation where most of the dollars spent in what we call healthcare isn't actually providing the care. So I just commiserate with you, but I think we're far from a one-payer solution, because there's too many people on every side that's making a lot of money doing it. But we should continue to talk about it. We should continue to advocate for policy that provides prevention and early detection without excess cost to the individuals who will benefit from it, because otherwise you end up with even more disparity in the outcomes.
Well, let's let that be the last word.
General strike.
So let's thank our panelists again.
I hope you don't need your